Hi, Sanket. Good evening.
Good evening, sir.
Okay. Hello, sir. Hello, good evening to everyone.
Okay, Chandan, okay, I can't see.
Yeah. Sanket, I'm not able to show my video on the screen.
Yeah, 1 second. They'll make you as a co-host.
Make you a co-host. Okay. Give me a minute.
We'll now you can try.
Yeah.
Is it working?
Just 1 minute.
So there are 7 minutes to go. I have also put the waiting thing on Facebook. So we are almost live now.
Okay.
Berat loh.
So you may thank you.
May I please mute?
Hello, ma'am. Bani login agi. Login agi. ನಿಮ್ಗೆ ಬೆಳಿಗ್ಗೆ ಡಾಕ್ಟರ್ ಅಮಿತ್ ಇಂದ ನಿಮಗೆ ಒಂದು ಇಮೇಲ್ ಬಂದಿರುತ್ತೆ. Good evening, Vijay sir.
Good evening, Sanket.
So you all are co-host. All the faculty will be co-host. You will have to control your audio and video.
Okay.
Yeah,
on
no
Facebook,
problem.
it is 6 minutes to go.
Swami Vijay Kumar ಅವರೇ ನಮಸ್ಕಾರ.
Vijay sir, you have to unmute.
ನಮಸ್ಕಾರ.
ಚೆನ್ನಾಗಿದ್ದೀರಾ?
ತುಂಬಾ ಚೆನ್ನಾಗಿದ್ದೀವಿ ಸರ್. ಲಾಕ್ ಡೌನ್ ನಲ್ಲಿ ಲಾಕ್ ಆಗಿದ್ದೀವಿ.
ಯಾರು ಲಾಕ್ ಆಗಿದ್ದೀರಾ?
Most of the people are get locked out at home.
Vijay.
Yes. Tell me, Sujata.
You were flying even last week. We are only under lockdown.
I was flying last week and it got so disturbed. We just can't even imagine. Every plan got collapsed.
Can you hear us?
I had a wonderful Bharat Darshan because of the flight cancellation.
Sir, we are now live on Facebook. And
Oh, sure.
We have participants also in now. 5 minutes to go.
Okay.
5 minutes to go. You connect my code.
Audio. Faculty will have to control their audio. I have muted Ravi Nirvani sir, please. Four minutes to go.
ನಾನು ಮಾಡ್ತೀನಿ ಸರ್.
Jay Lakshmi Shroff ma'am has joined us. Ma'am, you're a co-host now.
Hello, am I audible? Hello.
Yes, ma'am, we can hear you.
Yeah, sure. Thank you.
It is 2 minutes to go. We are live on Facebook and we have almost 92 participants with us.
Wait, sir. Do we need to wait for another 2 minutes or?
Yes, we will wait for 2 minutes more.
Okay.
Sanket sir, it is almost the time.
Wait, sir, can we?
If I have your permission,
Wait for a minute.
wait for me.
Where is the other 2-3 faculties?
They will join after the.
They will join after. Like
Maybe when they're.
Sanket, Hemant is here.
Yeah,
Hemant is not there.
Hemant is here, sir. He was
Then we
here.
might have to start with Jayalakshmi in the first course itself.
No, sir, Hemant was here.
She is there. And Dr. Srinivas is also there. So we can start with that.
Which one to start with, sir?
Hemant is there, na? Hemant is there.
Yes, sir. Yes, sir. I'm here.
Yeah, yeah. Then it's okay. Everybody.
There's a background noise, so you may have been muting some of the faculties.
Hello, Jayalakshmi ma'am.
I think the host has to control. There is the voice actually unnecessarily is coming from I don't know through some the speakers or a judge.
Yes, all the co-hosts will have to control their mic.
Now I think Dr. Amit, we can start.
Great. Thank you very much, sir. So good evening and thank you everyone for joining this beautiful webinar. I am Dr. Amit Borse and I head the PMT and Medico Marketing Initiatives at MCure, is a division of MCure and is a pioneer in the field of IVF. Programming 28 is a scientific theme for the year and hence our webinars are called Programming 28 webinars. Materna is a prime brand and is an epitome of quality and success. Today, we are very thankful for Academy of Clinical Embryologists, ACE, for giving us this opportunity to host this event. We are thankful to Dr. Ved Prakash sir, President ACE, and Dr. Sujata Ramakrishnan ma'am, Secretary ACE, for giving us this opportunity. This is a very fantastic webinar. And before I take you to the coordinators, Dr. Sanket sir and Ravi Nirvani sir, I'd like to take this opportunity to introduce our director, Mr. Nikhil Mehra sir. Sir, may I ask you to please speak a few words?
Sure. Thank you, Dr. Amit. Hello, good evening, everyone. I'm Nikhil Mehra. I'm working as a division sales head with Amcure Pharmaceuticals with its EVA division, mainly deals into IVF and hormone. On behalf of Amcure, I would like to take this opportunity to thank our conveners, Dr. Ved Prakash, Dr. Sujata Ramakrishnan, and to all the doctors and clinical embryologists who are present over here. It's the wonderful education initiative by Academy of Clinical Embryology. And just want to give little glimpse about Amcure. So we at Amcure are the global pharmaceutical company having presence to more than 70 countries worldwide. We are identified as India's top-ranked pharmaceutical company and #1 in the field of gynecologicals. So thank you, everyone. We'll be looking forward for more such initiatives along with Academy of Clinical Embryology. Thank you very much.
Thank you, sir. Thank you, participants, for joining in. Today we have Dr. Sanket Dhumar Satya sir with us. Sanket sir is an alumnus of University of Mysore, MSc in Genetics. K. Shrima IVF as Senior Clinical Embryologist and heads the Embryology Unit. Executive Committee Member of Academy of Clinical Embryologists, India. UA Team Leader at IHERA, Associate Editor at ACE Newsletter. Editorial Board Member of Journal JBRA Assisted Reproduction, Reviewer of 4 international Scopus Index journals, authored few publications, and to his credit, author and co-author of 3 book chapters. Principal investigator for several projects are Medical College, member of ISAR and Indian Science Congress, regular faculty in various national conferences, and delivered invited talks, lectures, and conducted multiple advanced workshops in the field of fertility. His area of interest is cryobiology and male infertility. Thank you for joining this webinar. We also have Dr. Ravindranath Nirvani sir with us. He is a PhD in reproductive biology, lab director and chief embryologist at Altus Hospitals and Cambridge Hospital, Bangalore. Executive committee member at ACE, executive committee member at KISAR, Kerala chapter. First to achieve Karnataka 3D embryo bioscopy. PGD baby delivered 2012. 7 national and international publications during his PhD program. We are very thankful for both of you to taking this program ahead, and the stage belongs to you now. Sanket sir, please take over.
Thank you so much, Dr. Amit. And very good evening to all, and warm welcome to this webinar organized by ACE. And it's a free webinar series and with the theme current practices in embryology. So now I would like to invite Dr. Ved Prakash sir for the presidential note.
Hi, good evening, everyone. So our second webinar of ACE this year, and I welcome all of you for fantastic webinar series. Again, we started with a very good theme, current practices in embryology. So I will not take too much time, and I welcome all of you. Please go ahead.
Thank you so much, sir.
Thank you.
Now I would like to invite Dr. Sujata Ramakrishnan ma'am, Secretary ACE, to give a secretarial note.
Thank you, Sanket. Good evening, everybody. We welcome you all to this evening program. The Karnataka group has put up a nice schedule. We have a couple of debates and a panel discussion. I hope this will keep you all engaged and enlightened during this evening. Welcome you all once again.
Thank you so much, ma'am. So without taking much time, let's start. I would be introducing the judge for the first. Dr. Amit, will you be sharing the screen? I'll share.
Yes, sir. Yes, sir.
So it gives me immense pleasure and honor to introduce the, I think, Vijay sir.
Sorry.
Dr. Amit, next slide, please. Yeah, next slide. Yeah. So great honor to introduce Dr. Vijay Kumar Chelu sir, who's a mentor for me. And sir holds 14 years of rich experience in clinical embryology. And also, sir has a distinction of conducting more than 8,000 cycles and also exceptional organization time management skills, and invited as speaker and faculty as a resource person in various national and international conferences. Welcome, sir. Over to you.
Thank you, Sanket. So with this, I think we can start the first debate, which is...
Sir, can we just give a small introduction about the speakers? I'll be sharing the screen, sir.
Yeah, sure. technologies. The first person who will be debating today regarding the cryopreservation of the embryos, whether it is to be freeze-all, it is Mr. Hemant Kumar, embryologist Hemant Kumar, who holds an MSc in biochemistry. He has a rich 11 years of experience in the field of embryology. He is the winner of the National Fertility Awards of 2019. And he is an executive committee member of Indian Fertility Society Karnataka chapter, and he has authored chapters in 2 well-published books, and he has authorized to perform cases of day 5 trophectoderm and day 3 biopsies for PGS and PGD this month. It's my great honor to welcome my good friend Jayalakshmi, who is a consultant embryologist at Ankur Healthcare, Bangalore. She holds MSc Biotechnology from Kuvempu University, and she was a junior embryologist at Gunashila, and later she moved on to Morpheus and then Manipal Life Sciences, and now she is independently consulting embryologist at Ankur Healthcare. She has very rich 20+ years of experience. She is very good at TISA, biopsy, sample preparations, IMSIs and PIXI techniques, and she is currently the executive member of Academy of Clinical Embryologists in India. So welcome you both, and let's start the debate right away.
Thank you, sir. Thank you for the introduction. Shall I share my screen, sir?
Yes, please.
What is the debate topic?
So freeze-all strategy.
Okay.
Good evening, one and all. First of all, I would like to thank his team for giving this opportunity today. Something is showing. Okay. Today, I'm going to debate on the most debatable topic, freeze-all strategy. I choose freeze-all for let's start with the introduction. Embryo transfer is a final and most critical event in the success of ART cycle. The freeze-all strategy is gaining popularity worldwide as an alternative conventional fresh embryo transfer. Initially, the freeze-all strategy was a rescue strategy for women who having a higher risk of overstimulation syndrome. Later, this approach has been extended to the other indication as a scheduled strategy to improve implantation rates. Today, it's amazing to see that the concept of elective frozen embryo transfer as a default for all patients undergoing ART is emerging. Then we look at the human embryo cryopreservation. Durga was the first IVF baby was born using gonadotropin and after the frozen embryo transfer by Dr. Subhash Mukherjee and Professor Sumit Kumar Mukherjee in October 3rd, 1978. But the history was registered by Dr. Allen and Dr. Paul in 1984. Because of due to the administrative reason, we lost our client. That is the first IVF baby born from the frozen embryo. Then freeze-all policies. What has made us think of a possible shift to freeze-all policies from fresh embryo transfer to freeze-all strategy? Mainly the evolutions we see in the cryopreservation techniques earlier from the slow freezing towards the vitrification, controlled ovarian stimulation during the ovarian stimulation, thus showing an adverse effect on endometrium and uterine contractions, preventing and eliminating the late onset OHSS, allowing time for sophisticated genetic test results, embryological reasons, especially slow developing blastocysts in the day 5 and day 6. And more importantly, the babies born from frozen embryos may have the better health outcome compared to the fresh embryo transfer. And not in the race, then live birth rates also showing in FET began exceed those with the fresh embryo transfer. These are the indications that we selected for the FET. I'm not going to explain in detail anything here. Then in the ovarian stimulation, that controlled ovarian stimulation does affect the endometrium. The lot of literature studies has come up with the controlled ovarian stimulation affect the endometrium. Controlled ovarian stimulation is necessary to the development and maturation of many follicles and oocytes. Therefore, it increases the chances of positive outcomes and cumulative pregnancy rates during the IVF cycle. The controlled ovarian stimulation, they're routinely using the exogenous gonadotropin to promote follicular development so that no oocyte may be obtained for the IVF cycle. So that developing follicles are typically more numerous than in natural menstrual cycle that collectively produce the supraphysiological estradiol and progesterone. That those supraphysiological levels of hormones are associated with the modification in the peri-implantation endometrium that may be related to decrease in pregnancy rates and poor obstetric and perinatal outcomes. The control overstimulation also they related in the endometrial advancement. This can be observed during the astrological evaluation during the first cycle. And control stimulation also alters the gene expression more than 200 genes, which is related to the implantation due to the supraphysiological level of hormones level, where the alter the receptors of estrogen progesterone that overexpress or under the exposed genes related to the implantation. And also in stimulated cycles, there may be an increase in uterine contractile and endometrium asynchrony. So the selective physio strategy, that dilatory effect of control over stimulation over endometrium would be avoided and better outcome would be expected. There is a study published in Human Reproduction in 2005 by Jose Antonio, effect of controlled ovarian hypostimulation with IVF on endometrial gene expression profile. In the study evaluating the endometrial gene expression profile, they performed the endometrial biopsy in the same oocyte, donor oocyte with the first cycle on the day after the LSH, on the day 7th day of after LSH, and the 7th day after the SCG trigger in the stimulated cycle. They found there were more over 200 genes related to implantation that over and underexpressed during control stimulation when compared to the natural cycles. So these changes may be associated with the supraphysiological hormones level observed during the control over stimulation. Then what is the effect on progesterone level concentration on receptivity? So success of ART treatment is associated not only with the quality of the embryo, but also the endometrial receptivity and embryo-endometrium interaction is also important. So many literatures and studies suggested that elevated progesterone level was associated with a significantly decreased implantation rate and live birth rate. And in the retrospective study, they're done with different protocol, with the long and short protocol, with two groups, with and without premature progesterone rise. The reported study was reported decrease the live birth rate in the premature progesterone rise group. So freezing the embryos and transferring from the later in frozen thaw cycle will be solution to improve the pregnancy outcome when progesterone levels are high. And OHSS, the physio strategy first initially was started to eliminate the OHSS and get the OHS free clinic concept. OHSS is our ovarian hypostimulation syndrome, is a major heterogeneous complications of ovarian stimulation. The OHSS is a potentially life-threatening condition with a massive ovarian enlargement. So in the OHS, usually that SCG triggering is the HCG is the culprit. During the SCG is the trigger factor of OHSS. Usually in egg maturation, SCG is used to trigger as the final final trigger. SCG is used as the trigger for the final egg maturation. Later, the pregnancy occurs, the SCG produced endogenously and also causes the ovarian hypostimulation syndrome. So always exogenous administration of SCG triggers the severe form of OHSS. So to eliminate the OHS free concept, the substitute with the SCG with gonadotropic agonist trigger can eliminate the primary OHSS. In the substitute SCG with physio strategy, virtually eliminate the both early and late onset OHSS. Then what does opponent may say about the elective frozen embryo transfer? Maybe the uncertainty of the safety procedure of the cryopreservation on cost effectiveness and patient compliances. There is a systematic review and meta-analysis done by Dr. Abha Maheshwari, the obstetric and perinatal outcome in singleton pregnancies resulting with fresh versus frozen embryo transfer. The study was concluded, systematic of this systematic review of observational studies suggests that pregnancies arising from transfer of frozen thawed IVF embryos seems to have a better obstetric and perinatal outcomes. So still that uncertainty is there about the frozen thawed embryo transfer. The uncertainty, why the uncertainty is whether the freeze-hold strategy has any effect on risk of miscarriages, embryo survival, and perinatal outcome after FET. So usually the lot of scenarios reported the effective frozen embryo transfer singleton have an increased risk of being a born of large of gestational age, which is not explainable by the maternal and factors or birth order. So in the singleton born after frozen embryo transfer are heavier, and there is a higher risk of large of gestational age compared to fresh embryo transfer. In contrast, risk of lower the risk of smaller gestation age in singleton born after frozen embryo transfer compared to the fresh embryo transfer. So the timing and consequences of the difference there remains is largely unclear. In the 2014, the paper was published in Human Reproduction by Pinboff. He was in study. He reported the freezing and thawing procedure may play an independent role for growth potential of fetus, maybe due to the epigenetic alterations at the early embryonic stage during freezing thawing, leading to the larger of gestational age. But knowledge about epigenetics and metabolomics are very limited. Then another paper published recently in Fertility Stability 2021 January. There is an evaluation of possible causes, the relationship with the large of gestational age from the frozen embryo transfer. Author was summarize the causes of association, which is increase the fetal weight and through the frozen embryo transfer. Maybe the absence of corpus luteum in the program cycle, supraphysiological estradiol level, and process of cryopreservation increases epigenetic modification. It is not clear if the modification is affect the fetal growth, but in some of the studies, different types of culture media, along with extensions of culture to day 5 and beyond, have been associated increased fetal weight that find in some studies. In another cohort study that based on 14,000 newborns, then look at the perinatal outcomes in children born fresh versus frozen embryos. The objective of this study was perinatal outcomes are affected by vitrification or by control over stimulation. The study was concluded perinatal outcomes are negatively affected by control over stimulation and not affected by the vitrification process. And by Abameshwari, a cumulative meta-analysis provided is the frozen embryo transfer better for mother and babies. They summarize in the cumulative analysis, there is a lower the risk of in frozen embryo transfer, the smaller gestational age, lower birth weight, very low birth weight, and preterm deliveries and very preterm deliveries are relatively lower the risk in frozen embryo transfer compared to the fresh embryo transfer, and larger gestation age and higher birth weight, which is relatively higher in frozen embryo transfer relative when compared to the fresh embryo transfer. Then the physio strategy, there is a dilemma is there was incident, it is only for the higher responder, not for the normal responder. The physio strategy is now developing may lead to the new era in modern ART. So, the study was published by Matthew Rhodes. He concluded in his study, physio policy may be related to the better in vitro fertilization outcomes in normal responder, but potentially advantages of these physio strategy in normal responder may be decreasing if the ovarian response was worsening. Then giving that the clinical and scientific evidence in favor of elective frozen embryo transfer is growing, why is that we have not already seen such greater acceptance of this strategy? Mainly because the patient preferences requires upskilling of IVF units, and major drawback was governmental funding models discouraging a freeze-all strategy. Chico messages, with the advent of newer technology like vitrification, the quality of frozen embryos and the potency for implantation are similar to the observed with the fresh. So frozen embryo cycles are gaining more importance in assisted reproductive technology. There is a growing evidence in supporting elective frozen embryo transfer, not only in the terms of high pregnancy rate, but more importantly in terms of lower maternal and infant morbidity and mortality. And many meta-analyses studies suggested that elective frozen embryo transfer in normal and higher responders, it may be advantageous and use them in a subsequent FET cycle. So still, freeze-all strategy as a default for all is still debatable.
Thank you, Hemant, for a nice presentation.
Thank you, sir.
Now, let us move on to Jay Lakshmi. Let's hear her words and then we can take a conclusive remark.
Sure, sure.
Over to you, Jay Lakshmi.
Yes, sir. Thank you so much. I hope I'm audible.
Yes.
Yeah,
Yes,
you can
yeah.
increase your volume a bit. Yeah.
I have
Audible.
a problem with
Yeah,
yeah.
that's fine.
Thank you so much. So should I share my screen?
Yes, absolutely. Go ahead.
Yeah.
I request Dr. Hemant to stop sharing.
Yeah, I'm getting this one.
Yeah. Good evening, everyone. I'm talking against freeze all. Now, Hemant has spoken, I think, both the aspects. So I have very little to say now, but anyway, I'll try to prove my point by I am not for freeze all strategy in the IVF cycles. So the first thing is, why are we debating here? We debate on ICSI for all, we debate on PGS for all, we are debating on freeze for all. So if the concept is clear that we can apply this all strategy to all these for all the patients, so there shouldn't be any topic of debate, and people should accept all this all strategy for all these procedures. But no, we are still debating, because there are positives and negatives of all these strategies. So let us see the little advantages of freeze all policy. Yes, definitely there are advantages. The freeze only policy is majorly for where all the good embryos are frozen and transferred at a later cycle. So this definitely avoids the hyperstimulation where the endometrial receptivity is altered. It definitely improves the outcome in cases of recurrent implantation failures. For embryo pooling, where the poor prognosis patient, where the cohort, I mean, the number of embryo oocytes we retrieved are very less. And for the fertility preservation, either for the medical reason or the social indications, and of course for the donor cycle, where the embryos are created, stored, frozen, and all are frozen and then transferred in the subsequent FET cycle for the recipient. Now, coming to my topic of the day is the disadvantages of this freeze all cycle. The cost of the cycle is definitely more, because the cycle ends with the freezing, and generally freeze all policy is where we get the number of embryos are more, so the freezing cost is increased, and again the FET cost is increased, where the thawing and the priming of the endometrium, and the patient has to undergo again scannings, so the cost is increased. The time to pregnancy is increased, because we freeze and then call the patient for the next cycle, and here again, if the endometrium is not prepared in the next cycle, again the patient is called. So the time to pregnancy is definitely increased here. Survival of average to poor quality, if we just apply this freeze all policy for all, what about these poor quality embryos? I definitely understand vitrification has given a good survival rate for the embryos, but still we know that certain poor quality embryos do not survive freeze thaw procedure. So survival of average to poor quality embryos is again a question. The epigenetic effects, yes, the studies are limited, but that is the key point here, that we don't know what is the epigenetic effect of these cryoprotectants. And there is an increased risk of hypertension in mother in pregnancy. The large for gestational age and higher birth rate is in singleton pregnancy is more in frozen thawed embryo transfers. So there is a analysis of which is there in for the non PCO women. It says that this analysis examined the cost effectiveness of freeze only versus fresh strategy. So the RCT has not shown any significant difference in effectiveness in live birth rate between two strategies. So the conclusion was the fact, the cost need to be taken into consideration when deciding whether to use for freeze only versus fresh ET strategy. The table is from the same paper, where it shows that there is there is a cost difference with a significant p value, and the total cost, if you can see, the total cost is also higher for freeze only strategy. So, and moreover, the freeze all method does not improve the live birth rate in non-PCO or unindicated group of patients. So the same paper again says that the live birth rate is not very significant between freeze only and fresh ET. So this is about the cost. So coming to the cumulative birth rates following a freeze-all strategy, this is a population-based study. So the second graph, you can see that less than 10 oocytes, when they are retrieved, the freeze-all strategy doesn't work. So the cumulative birth rate is more in fresh transfer than the freeze-all. Yes, it is actually applicable when there are more than 15 oocytes. That is definitely the hyperstimulated cycle. So now coming to the effect, the epigenetic effects of the cryoprotectant. This is a very beautiful paper which actually explains the epigenetic effects for on the embryos, the freezing procedure on the embryos, for the sperm, and even for the oocyte. So this says that gene expression was shown to be different in frozen thawed embryos when compared with fresh ones in different species such as humans, rabbits, mouse, and bovine. So this definitely explains that there is epigenetic changes, there is changes in the gene expression when you freeze thaw the embryos. So this is again the physical factors and the chemical factors which affect the frozen thawed embryos. Now, this paper says that singleton born after FET have higher risk of higher birth weight, being large for the gestational age, compared to the singleton after fresh ET, and even compared to natural conceived singleton. We all know that the ART babies themselves have got so many problems, and again on top of it, going for a complete freezing and thawing and then transferring probably will increase the problems more. So they say that we assume that the freezing process might be the underlying cause for this. Sorry. Okay. This paper from KM Wong, it is published in 2021 itself. It says that our findings suggest that a freeze-all strategy of blastocyst does not result in a better cumulative ongoing pregnancy rate in unselected groups. So the underlying point is that you cannot apply freeze-all for everyone. Yes, for a selected group of patients, it is definitely working, but unselected group couples where they are going undergoing IVF, this doesn't work always. So this paper abstract says that, however, freeze-all is associated with significantly higher perinatal complication, including eclampsia, preeclampsia, chronic hypertension, and LGA, and without the demonstrated advantage for providing better results except for a decrease in the incidence of OHS. So this paper clearly says that the freeze-all policy is definitely applicable for OHSS, definitely advantageous, but then it's only in the case where the patient is hyperstimulated. And now coming to the Cochrane live review, this is the what they published. I have just taken some key features on this. So the key features, what the Cochrane Library Review says is the risk of OHSS is definitely decreased with the freeze-all policy. The time to pregnancy is likely to be less in fresh ET. And risk of maternal hypertensive disorders, again LGA, higher birth rate, they are more increased following freeze-all policy. And there is little or no difference in clinical live birth rate and ongoing pregnancies with freeze-all policy. So where should we apply? We actually should apply this freeze-all policy. Again, coming to the same point, where there is a high risk of OHSS, where the endometrium is altered, or high levels of E2, for definitely for PGTA, PGTM, for embryo biopsy. This is a good option. And in case of premature rise in concentration of progesterone, Hemant has already explained this. In case of poor endometrium, where after the OPU, the endometrium is not showing good prognosis for the embryo transfer and definitely for the fertility preservation. This paper published in 2020 also gives the list of the reasons where we can apply freeze-all policy. So what I can conclude is vitrification is a great tool. We have seen from the slow freezing how things have changed, how the vitrification has helped. The kind of survival rate we get from the vitrification is extremely well. But then again, we need to use this technology with caution, because Buddha says everything excess in life is poison. So thank you so much. And I hope I have proven my point. Thank you.
Thank you, Jayalakshmi and Hemant, for a wonderful debate. Now, if I were to pass at this one, going through both this one as well as the personal reading what I have had, freeze-all policy works only for OHSS and normal to high responders, not to all, number one. Number two, OHSS, even today, it's a dilemmatic situation because it is, I think Dr. Suresh Katera would also like to add to this. My personal opinion is this, that it is an iatrogenic controlled ovarian stimulation. Not every clinician ends up into having OHSS in nearly 30% of his stimulated cases. I have seen few doctors with whom, when I was working with those clinicians, I never get to see OHSS. So it is an iatrogenic thing, but that is not our purview here. What causes OHSS, how they can control it, why few people only get it repeatedly is a totally different ballgame. We need not have to bother. But I personally think that OHS is very much predictable, controllable in controlled ovarian stimulation stage itself if the clinician is better at it. So once if we can control OHSS in a precise manner, that automatically takes our way back from the freeze-all policy. Freeze-all definitely is a cost adding factor. In India, where the patients are paying by themselves, cost is a factor to be considered. In Western world, in certain places where marginal funding is available to the patients, where they would like to have this particular cost factor analysis and everything, and they would like to say that it still works out, it's fine. But in India, patient is paying by themselves. So any additional cost, if we are trying to give it without a market benefit in that, I think it is not right in our policy. Now, Hemant was right in pointing it out that initially the freeze-all policy was better working in high responders. But now we have a conclusive remarks coming out that people with normal ovarian reserve only get benefited from the freeze-all policy. People who are having poor ovarian reserve, people who are having problems of premature ovarian problems, these people do not get any benefit from the freeze-all policy. So that's why freeze-all has to be adopted very specifically. And freeze-all to work, if you look at the papers very carefully, the published papers, you will notice that the very hypothesis they come out with the freeze-all policy is the erratic rise in the estradiol and non-timing estradiol. But in the thawing cycle, when the patient was being transferred, near about 50 to 55% patients were primed with estrogen there. It was not a natural cycle. So this whole hypothesis of erratic E2 dies there itself. If it is that's the case, then you should do it in a natural cycle. They will be doing it in an E2 primed cycle. Sometimes I have seen people who do freeze-all give estradiol valerate 18 milligrams a day for about 8 days and then schedule the embryo transfer. So if you are giving so much of estrogen even after doing a freeze cycle, then freeze-all was not needed. Even a fresh cycle would have given the same result. Then if we compare the result factor, only in cases of PCOS, freeze-all has proved better. In all other this one, it is equally comparable with the fresh embryo transfer. So judiciously speaking, we should keep only for PCOS patients, only for patients whom you can predict primary OHSS in a well-behaved manner, early manner, preserve for freeze-all, rest all, you go as the case demands. Do not add cost to the patient. Thank you. Thank you both the debating people.
Can I add one small point, sir?
Absolutely.
Yeah.
Please go.
I somehow feel the vitrification has given so much of courage to the embryologist and the
Absolutely.
that they don't mind actually hyperstimulating the patient.
Absolutely.
So I don't know whether we ourselves are, altering the results here.
Absolutely. See, the epigenetic modifications, what cryoprotectants can bring in, we were discussing even in our slow freezing methods also. In slow freezing, the average and poor quality embryos used to be always knocked out. We never used to get survival beyond that. Now the survival of this vitrification has given a false confidence, or I can say that it's a fake confidence among the users, and they are proposing all these strategies. Thank you.
Hello, can I come in?
Yes, please.
Vijay, this is
you're most welcome.
This is actually the debate. I think you are a judge. You let them to fight. No, because no, somebody has to speak about.
No, absolutely.
And,
they have given up their points, and I am just concluding.
Both the speakers are very cool. Okay.
Yes.
They are not debating. They are not fighting. Anyway, in the brochure, it is mentioned that 10 minutes audience interaction. Is there a
absolutely
chance?
No, sir. I think we are running short of time.
That's why, because it is online. No, we'll have to stick to that time. So
absolutely.
Convener should stick to that one. Anyway, if there is no chance for audience interaction, let us move on.
Yes, absolutely. Good.
Thank you so much, Hemant and Jayalakshmi ma'am, and thank you so much,
It was
sir, for
wonderful
that.
having you both here, and you presented your points very well and in a very cool manner. Thanks for that.
Thank you so much, Vijay sir, for that nutshell on freeze-all. And over to Dr. Ravi.
Thank you very much, Sanket, for inviting me here in this platform. So next topic of debate is like time lapse. So for that, I'm going to invite Dr. Srinivas here to judge the session. Over to you, Dr. Srinivas. Sanket, can you share me the slide? Okay, I'm going to introduce Dr. Srinivas. You know, Dr. Srinivas is a well-known personality in the field of embryology, especially in Indian scenario. Dr. Srinivas is the founder president of ACE, Academy of Clinical Embryology India, and he's also a course director for MSc course in clinical embryology. He's a vice chairperson for ISAR Embryology also, and the scientific director for Narayana Health Hridayalaya in Bangalore. He's a past president of KISAR, Karnataka chapter, and he's a director of business development for IVF Precision. ICMR expert committee member also. Over to you, Dr. Srinivas.
Thank you so much, Dr. Ravi, for a nice introduction. I'm sure this is the second session of a debate. This debate is going to be between Faizullah and one Mr. Dilip Kumar, who is from Bangalore. These two bulls are fighting in favor of time-lapse, and Faiz is going to speak in favor of the time-lapse video monitoring, how to monitor the embryo, how to select the embryo. Then the Mr. Dilip Kumar is going to speak on against time-lapse actually. I think, anyway, this is going to be a debate. I would request both the speakers to add a fragrance of the debate, this thing, so that it is going to be useful and attractive for those who are joined in the webinar. Okay, I think this is a 15 minutes talk for each. In that 15 minutes, 12 minutes Faiz has to speak. 3 minutes you will have to reserve. Similarly, Dilip Kumar, if it is a 10 minutes, 7 minutes.
10 minutes.
I don't know, the convener, it's a 10 minutes or a 15 minutes?
10 minutes, sir.
10 minutes means 7 minutes you will have to prove in favor or against. 3 minutes you have to keep and the both of you are going to debate, and I will be concluding. As you all know, time-lapse video monitoring is there last 10-15 years. I think still it is not reached to the point where each and every ART clinic will definitely go for a time-lapse video monitoring, assuring the patient or couple for increasing the success rate. Okay, with this, I will welcome Faizullah, whom I know very well. They are close friends of mine, even Dilip Kumar also. I don't have their slide to speak about. No, can I have a slide? Faizullah,
sharing it, sir. Is it visible, sir?
I'm not able to see.
Is it visible, sir, now?
Put it in the, okay. Faizullah is senior most IVF clinical embryology. He has 9 years of experience in the field of clinical embryology, that's in assisted reproductive technology. Currently working as a chief embryologist and a teaching faculty at Garbhagudi IVF Hospital, Bangalore. As an international worker, experience as a clinical embryologist license from that is from the Oman. So he has worked in so many places at the embryology. He has a good experience, and he is going to speak on in favor of the time lapse. So Faizullah, you have 7 minutes to prove yourself. Next is Dilip Kumar, whom I know very well. Is currently working in Milan as a senior most clinical embryologist. He has been training so many embryologists, taking the class. He has contributed for many books as a the chapters are related to the ART field, and he has done specifically the embryo biopsy, that's the cleavage stage, and tropectoderm biopsy, and he has co-editor for many books related to ART. Over to Faizullah. Faizullah is going to speak first.
Thank you so much, sir. Good evening, everyone. So I'll start sharing my screen here. So good evening all. So the topic is today about the time lapse. So before starting the session, I would like to declare that I don't have any special interest or any affiliation with this particular product that we are going to discuss today. So first of all, what is this time lapse is? An embryoscope or the time lapse is a new type of incubator that allows the embryologist to monitor embryo cell divisions while the embryos are still in the incubator. The incubator, this time lapse incubator, has a built-in camera that can take pictures of the embryos at the timed intervals. These pictures are then combined to create a time-lapse video showing the embryo's development at every vital stage. So this is to avoid embryo stress, which can reduce the quality of the embryos and therefore the chances of pregnancy also. So what is usually happen in the conventional incubator, the embryologist will remove the embryos and then check under the micromanipulator to evaluate the embryo on a timed interval gaps. So the embryo's development will be viewed by an embryologist at longer intervals also in the standard incubator. Some information will be missing, such as exactly when the embryo is divided. So this is when we grade the embryos conventionally. Whereas in time lapse, we can just grade the embryos by keeping them inside the incubator itself. So we will have undisturbed cell culturing system with the embryoscope. So embryologists can see the embryo's continuous development over several days. So whereas in conventional incubator, we will have certain time limit that where we can just take them out and then keep them back. But in embryoscope, definitely we will have a continuous monitoring on the embryos. And then we will get enhanced information available to help identify the embryos with the highest potential of pregnancy. Along with this, we can just keep a copy of their embryos from the time-lapse video. So the major advantages of using this time lapse is we can perform the ICSI at any time. So we no need to delay the procedure based on our fertilization check on the next day. So this is the very big advantage that we will have when we use this time lapse incubator. And during IVF cycles, I think we can proceed with the short insemination and denudation, and then keep them back into the embryoscope. So we will not miss any fast and or the late fertilizations and any other abnormal morphokinetics when we use this time-lapse incubator. So standard methods of embryo assessment, yes, we will have a very standard techniques that we can grade the embryos with this time lapse. So defining the validating predictive parameters using evidence-based data is one more advantage of this time lapse. Processing abundant imaging data in real time. So during this pandemic season, it is very difficult for being an embryologist to go to the laboratory and check the embryos on daily basis. So one more major advantage that we have by using this time-lapse monitoring system is that we can access this embryo development stages by sitting at home also by using this embryo viewer system, which it can synchronize with our mobile screens, and we can see the embryo development at any sitting at any place. So this is a very big advantage that we can say about this embryoscope. We are not going to miss any embryo development at any stage. So talking about the Istanbul consensus, according to the guidelines, we have to check the fertilization check on day 1 around 16 to 18 hours, and day 2 will be around 44, and day 3 68, and day 4 92 hours, and day 5 assessment will be 116 hours. So practically speaking, sometimes it is not possible for an embryologist to be at that in the lab at that point of the time. So what will happen if we cannot check this embryo developmental stages at this crucial points? Sometimes we are going to miss something which is very important, that is the fertilization. So we may miss the abnormal fertilization also. It can be like 1 PN or 3 PN or multiple PNs also. And then later on, these abnormally fertilized zygotes can reach the blastocyst stage also, and then we will end up with a negative result or an early pregnancy loss also sometimes. So apart from this abnormal fertilization, the embryos sometimes will undergo abnormal cleavage patterns also. In that, this direct cleavage is one of the major pattern. So here in this video, they have shown that the embryos directly are cleaving to 3 cell stage from the PN stage. So usually the embryo should go to the 2 cell stage and then 4 cell. So but here the abnormal cleavage pattern, we can see that it is directly cleaving to the 3 cell stage. So such kind of incidents will occur up to 26% of embryos, and to reduce chances of implantation after the embryo transfer. So here in this paper, they have very clearly concluded that this paper was published in Fertility and Sterility Journal. So the study population was around 815. So here they said that they spoke about one more abnormal embryo cleavage, that is embryo reverse cleavage. This can also happen at any stage of the embryo from day 1 to day 5. So here they said that reverse cleaving is significantly compromised embryo development and then the implantation potential as well. So in this pie chart, they have mentioned that the reverse cleavage embryos, whatever the embryos that had a reverse cleavage have very 0% of implantation rate, and whichever the embryos got implanted had only 4.5%, that too without fetal heart rate. Whereas the embryos without reverse cleavage got implanted 22%, and with a 5.4% of fetal rate. There is one more publication. So here, this is also published in Fertility and Sterility. So this in this paper, they have spoke about this morphokinetics evaluating through the embryoscope. They have concluded that the strategy of culturing and selecting embryos in the integrated embryoscope time-lapse monitoring system improves reproductive outcomes. So here we can see that the time-lapse group and the control group, the ongoing pregnancy percentage is higher than the control group here. So the ongoing pregnancy is around 55% almost, and whereas in the control group it is 45%. And the early pregnancy loss is around 16%, and whereas in the control group it is 25%. So the early pregnancy loss is higher in control group, where they have used only
As you
the
have taken
conventional.
8 minutes, 8 minutes you have taken. I told you to conclude within 7 minutes.
Yes, sir. Yes, sir.
Okay,
Done.
conclude quick.
So this is about the light which we use in the embryoscope time-lapse incubator. So they have concluded that this red light will not affect the embryo development at any point. So it is safe on the embryos also. So with this, I would like to conclude that using this embryoscope will definitely improve the embryo selection, better selection, solving the observational dilemma, undisturbed stable incubation, and then constant time-lapse monitoring, and then reduce pregnancy loss also, and we will have electronic medical record integration. So when we can upgrade ourselves from all such things, I think this is very crucial time to upgrade from a normal conventional incubator to embryo scope. So I think this is the time for change. Thank you, sir.
Okay, thank you so much, Mr. Faiz, for explaining in the use of time-lapse in favor. Now I would invite Mr. Dilip Kumar to speak against time-lapse. Dilip. Dilip, are you there?
Yes, sir. So, is audible, sir?
Yes, yes, go ahead.
Yeah. Good evening, everyone. Thank you, Sayed, for the good input about why it is so important of time lapse. But if someone asks me time lapse is important, I say that no, in the right situation, I think I don't give the space for the time lapse in my lab. So I start my session by quoting the statement: the false claims of effectiveness to take the financial advantage of desperate couples. I just took this statement from the Rutherford 2017. He gave one.
Dilip, put your screen for the slide mode.
Slideshow.
Yeah.
Yes.
So I feel this the statement is appropriate for the today's discussion. So why? Because everyone know that the first birth of the Louis Joint born 1978. Till then, there is so many millions of babies are born. But when you look into the success rate, the overall success rate in each clinic, the success rate we are not reached. People says that the implantation and all. What about the live birth rate? That is still not be reached. So overcome. There is actually that. Countless adjuvant therapies and techniques is introduced in the last few decades. So we can call that is as a fertility add-on. For example, like egg activation with the calcium ionophore, embryo glue, selective freeze-all and assisted hatching and pre-implantation genetic testing and time-lapse imaging. So, so even history and human fertilization and embryology authority clearly says that this all the fertility add-on. So I'll justify. I give with a total observation which I made and with the evidence why it is add-on. When I personally look into the so many time-lapse imaging, I don't want to take any the time-lapse name here. I just overall I believe the time-lapse system, when I observe, there is a distinct light exposure. Definitely when it is each time when you capture the image of the embryo, the light exposure, even the science told that it is a evidence that it's not going to affect, but there is not much evidence for that. And it due to the motion, when there is a dish, every time it is keep on moving, when you're capturing the picture, definitely that motion is going to affect friction of moving part and magnetic field and stress of moving culture dish and lubricant related to time-lapse system maybe bring to the hormonal effect to the embryo quality. And in the other hand, everyone know that time-lapse system is so good that it is a lab tool. It will give the excellent annotation of the morphokinetics. And when but I says that embryo kinetic may be a blend instrument to detect normal embryos. Yes, Syed, you told that even I did the study on the time-lapse. The two polar body exclusion is correlated with the quality of embryo. But excellent, we got excellent blastocyst and overall. But how do you know that the blastocyst is metabolically and chromosomally normal? We don't know. The instrument will not going to say that the embryo is metabolically and chromosomally normal. On what basis you're going to select? Even I'll agree that so many statements give that single embryo transfer will give the better pregnancy and it will reduce the multiple pregnancy chances. But how do you find out whether that the embryo which you're going to select metabolically and chromosomally normal? No evidence, not much evidence. And in embryo culture, so you visualize observation. So few of the time-lapse instrument, you can observe in the single plane. You're not going to see in the 3D. But when you see in the single plane, definitely there is a like overlap of the blastomere and eye level of the cytoplasmic fragmentation. Definitely, I don't think it will give the clarity of the embryo which you're going to select, and the annotation we're going to record that it will be good embryo or not. Then this is the big cost benefit to the Indian market. So okay, Indian market, one of the doctor asked me the question, when you're giving the presentation, what is the cost of the time-lapse imaging? So everyone knows that what is the cost of them. So with the lesser than that, when the embryology is going to set up, what is the point of the investing so much on the time lapse? Okay, I'll agree. If you invest a time lapse, does not improve the pregnancy rate. Then when you invest, like when you invest, it will give the clarity that it will give more pregnancy rate. That will be big question mark. So right, but this all the observation which I made, and it's a general discussion which happened between the clinician and embryology. But when I come to the with evidence, see anything which is introduced to the market, like evidence-based medicine is very important. Whether he's a professional, a research artist, a scientist, anyone, when he is introduced anything new to his lab, he asks that show me the evidence. Right. Some medical professionals negotiate the use of the new add-on. So I'll tell you new add-on fertility for the treatment so with a limited evidence. And apart from that, big organization and bigger commercials, they have the huge like amount. Definitely they go for the time-lapse system so that they can marketing their lab so that people get a more revenue, I think. So that is one of the strategy. With available RCTs. So it's very clear the meta-analysis of randomized controlled test is a big high quality evidence. So with available RCTs, detecting and effectiveness of the time-lapse system, so far given divided into 3 types. Okay, studies comparing TLI incubation to the conventional incubation, the studies assessing overall impact of the TLI to the conventional method, and studies focusing on potential effect of TLI and morphokinetic monitoring and embryo selection. Even my Syed, even you were like showing all the research paper, you are not seeing any single paper that give TLI incubation give more live birth rate than the conventional incubation. I had not seen any article, any evidence that you say that, yes, I'll agree. It will give the more insight, observation about the embryo. Everyone has a curiosity that how it is growing. So definitely I'll be like a fan of the things, but certainly when you invest of so much of big amount, there is outcome should be important to clinicians and embryologists, even the organization. And even though there is a 2 recent Cochrane review concluded that there is insufficient evidence of increase the live birth rate justifying the use of the TLI over the conventional incubation. So I think there is a more research work is needed. I think you show that in the coronavirus time, it is not right to touch. Definitely in the coronavirus, getting the salary is a very big hurdle here. And I don't think the investing so much is a very big problem. I don't think no one will be go for. If you ask me, sir, it required a lot of research work, a lot of work is required, a lot of RTC is required. Prove that this incubator TLC is more give the live birth rate. I'll come to the conclusion says that it is inefficient evidence to support TLI is superior to the conventional method. And what all you want to present some papers or RCTs. I don't think it all like low quality evidences. I think we need to design more RCTs which give more like effective clinical TLI use. Why we want to use. So these are some of the references which I used for this. And finally, I'll say that time-lapse system in the lab, I don't want to waste the space, and I don't want to waste the expensive consumables and the space also in my lab. So I don't say that in the right situation, I think a lot of evidence is required. I don't say, no, don't go for the time-lapse. Still, evidence proves that it will give more live birth rate. Thank you very much.
Okay, thank you so much, Mr. Dilip Kumar.
Yes,
Speaking against time lapse, you actually contracted Faizullah. Why no, we should not have a time lapse, and you are asking clinical relevance, and because you are also stressing upon clinical based evidence. Okay, now before I give you three minutes, let me highlight a few points. Actually, when Faizullah was discussing about, he has pointed out a few points. Okay, in his term, it is fine to check fertilization, whether a normal fertilization or abnormal fertilization. Conventional IVF, whenever you do it, you might miss this one. So time lapse it uses early cleavage, fine, and reverse cleavage. I just want to ask Faizullah, reverse cleavage means two cells to one cell. That's what you mean, isn't it? Faizullah, are you there?
Yes, sir.
Okay,
so
fine.
It can be 3 to, I mean, 3 to 2 or 4 to 3,
yeah,
whatever.
this is what you meant. But at the end of the day, what the patient is required actually, their pregnancy and the baby is delivered, live birth rate. So that is where the debate is focused on. When Dilip Kumar was talking about, actually, he has mentioned about, and he has also contracted your point, coronavirus. During coronavirus, you can sit at home. Okay, you can watch embryo eternal. This is one point is fine actually, but like Dilip Kumar said, having spent so much money, okay, during the coronavirus, no, even embryologist salaries is also cut. Okay, you are put a nice point actually there. Time he has contracted about the spending so much money and the salary cut also, but there are various kinds of time-lapse video monitoring actually. Initially, there was only one. There's so many companies have come up actually. Then it is confusing also. Which one to use actually? Which one is giving a good result? Because it is become a subjective now. These company people will just tell, okay, embryo grown like this, embryo will not be disturbed like this. Though it is moving means it is fine. So then normal pregnancy, it is not like that. People are keep moving. These are all things that, but the various companies are coming to various the equipment. There is no single annotation or because each one has their own way of grading the embryo. So this makes the embryologist to get confused. So some extent, okay, because almost 15 years it is there. Some extent it is okay to deselect the embryo. When you send the embryo for PGS, okay, if you deselect the embryo and send it, and you will be able to get more on. But finally, what if you are believing in evidence-based actually, or clinical relevance, what is the take-home baby rate, baby born out of this, whether they got to. So this is what you have discussed. Still, I will give you 2 minutes each actually, if you want to speak something, and Dilip Kumar wants to speak thing, you are welcome. You want to speak one. Use another 2 minutes, Faiz now.
Sir, sorry to interrupt. We have only 2 minutes left.
Sir, shall I?
1 minute,
Sir,
1 minute, please. 1 minute.
Sir, shall I?
Okay, Dilip, if Fayaz is
Sir,
not...
I say definitely the time-lapse system is a very beautiful lab tool where we get a lot of annotation, like even like we don't know about like 3PN and so we get a lot of information that, but ideally that is suitable for the research organization right now. Because see, every clinic, they're looking for the live birth rate. Now, if you ask the patient, they don't want any explanation. They ask only, give me a baby. See, in that situation, investing so much, I don't think baby is required a lot of work. But in the research oriented, it is a beautiful instrument. I got a lot of information about even I'm observing the embryo, we got a lot of information. So I'll say that it is good for the research than the IVF lab.
No, anyway, somehow you are also not against a time lapse. Anyway, it is.
I'm not less against to the IVF, sir. IVF lab. I'm against to the IVF lab. I'm not against to that.
You are giving a hint actually, because the research. No, what you say, you cannot do research with the human embryos. Okay, leave it. Okay, it was a really wonderful debate. Both of you debated very well. Time lapse monitoring system. If you want to, always clinicians want a clinical relevance. We always have to use any advanced technology if there is evidence-based, because we believe in evidence-based medicine. Clinical relevance is there, it is okay. Some extent it is pro-timeless, fine. It is left to the IVF lab whether to buy or not. But the couple wants a baby. The take-home baby rate should be compared before we go to any advanced technology in IVF lab. With this, I thank ACE President Ved Prakash and the Secretary giving me an opportunity. I'll also thank MCure for sponsoring this particular program. Thank you so much.
Thank you also. Thank you.
Thank you.
Thank you so much, sir. Thank you so much, sir. Yeah, please, sir.
Thank you. Okay, thank you, Dr. Srinivas, for giving a very good information about these two guys who have presented their views with respect to time lapse used in day-to-day in our IVF practice. Now, I'll hand over the things to Sanket for your next session.
Yes, sir. Thank you so much, sir. Dilip, can you stop sharing your screen? Yeah, thank you. So I'll be introducing the moderators and the panelists for the panel discussion. So all are quite well known and needs no introduction. So I'll be quickly introducing all of them. So firstly, Dr. Suresh Katara. Sir is working as a director at Asia Pacific Institute of Embryology, Mysore. And also sir is also a director for multiple IVF centers in India. Welcome, sir.
Thank you.
And next is Dr. Vasha Sansan Roy. Madam is a scientific director and chief embryologist at Manipal Advanced Fertility Center, Bangalore, and also past president of ACE India. Welcome, ma'am. So coming to the panelist, next is Dr. Chandan, dear friend of mine, and is currently working as a consultant embryologist at Kangaroo Care of Women and Children Hospital, Motherhood Fertility and other fertility centers, Bangalore. Welcome, Chandan.
Hi, Sanket.
Yeah. Next is Dr. Gayatri. She's currently working as a lab director and chief embryologist at Sarvodaya Women's Hospital and Fertility Center, Dharwad. Welcome, ma'am.
Thank you.
And next is Swapna Reddy. She's a senior embryologist at Cloud9 Fertility, Bangalore. Welcome, Swapna. And the next is Sanjay Etnale, a dear friend of mine, and he's working as a senior consultant embryologist at Pune. Welcome, Sanjay. And we have another one is Dr. Ravi Nivani. Welcome, sir.
Thank you, Sanket.
So without taking much time, over to moderators. Ma'am, sir.
Hi, good evening, everyone. Let me, Dr. Varsha, can you share the, yes, thank you. Okay, good evening, everyone. Today's panel discussion is on embryo biopsy, day 3 and day 5. And I, along with my co-moderator, Dr. Varsha, would like to invite the panelists for this debate, panel discussion. Before we start, I would like to give a brief introduction. As you all know, a close tie exists between clinical embryology and genetics. The aim of PGT is to identify euploid embryo so that we can avoid the transfer of abnormal embryos and serious genetic diseases. Also, we can reduce the incidence of miscarriage. As you might recollect, it's almost 30 years since the first IVF pregnancies were reported in 1990 from Hammersmith Hospital by Alan Handyside. Since then, the field has developed and progressed, both in terms of the embryology biopsy laboratory and also the genetics laboratory. Progress and development. And with this panel discussion, we hope to be able to deliver some message today. The first question actually over to Chandan.
Yes, sir.
What are the basic requirements in terms of infrastructure?
Before I start my speak, I would like to thank ACE for considering me and inviting me to share my knowledge. The first question, as you asked her, like, what are the basic requirements and infrastructure? With respect to my point of view, the basic infrastructure would be like, we should have a proper laser system. Of course, we do have, I hope you guys are audible.
Yeah, we can hear you.
Yeah, okay. So as I was discussing, of course, we need a proper laser system. So in spite of we get a laser system on rental basis, what I would suggest is it's better to have our own laser system equipped with, so that we don't find the last minute issues like laser is not working, setting up is a problem, and all those stuff. So one is a proper laser system, and the biopsy person should be aware of what kind of laser system which is using and how to handle it. And in spite of this, I would like to say that how to troubleshoot a laser system is the most important thing which I would suggest. So these are the basic things which I always expect when we do a biopsy system. And of course, apart from that, a proper disposables unit and a proper system where you maintain a proper environment where you can do your biopsy procedures. These are the things which I would like to highlight.
Okay, Dr. Gayatri, can you a little more elaborate on the equipment and the instruments?
Yes, sir. Equipments properly installed and calibrated micro manipulation system should be available. Incubators and designated laminar flow hood should be available, and efficient cryopreservation program should be there. These all things, and micro manipulation tools should be available. All the basic requirements, even medias, everything, and a close collaboration with the PGT center, like depending on their protocols, it has to be done. So these are the basic things.
Disposables and consumables.
Yes, sir. They also should be of IVF grade.
Now over to Swapna.
Yes, sir. Disposables, consumables, first thing is we need to stock check, and the IVF graded disposables we need to select.
Okay, can the remaining panelists add anything?
Yes, sir, I would like to add a well trained and qualified embryologist to the, it should be the main thing of the PGD setup.
No, I just want you to, add if there is anything, for the basic requirements. We'll go to that, in the next slide.
The thing is that
So
the basic, yeah. Sorry, Chandan, you can.
Okay. So before that, I would like to add 2 points on this. The excavation which we use we should cross check whether that is suitable for the laser system which we are using. And before laser, we have to make sure that all the calibration and the system is working fine. Your calibration system is working fine, because assisted action is a very skillful technique. And last minute, if we find any difficulties, if the joystick is not working, if the laser shot is not exactly where it was supposed to be, all this can create mess when we do an embryo biopsy procedure. So understanding an equipment and having an updated equipment is what I would always recommend.
Dr. Varsha, can we have the next slide, please? Okay, so in terms of infrastructure, though it is not possible to have a dedicated area, your embryology laboratory should have the necessary equipment. You cannot have a separate micromanipulator for this purpose, but as long as you maintain the room quality control, then air quality, which should follow the ASHRAE guidelines. But in countries where it is regulated, there are certain specifications which you need to follow. And for tubing, though we say there has to be a dedicated area, it can probably still be done in the embryology laboratory. In terms of equipment, of course, the standard ones, the inverted microscope with whichever brand of manipulator, as long as it has good control and with a non-vibrating table. Laser, there are different brands with software camera and then a stereo zoom in your laminar flow. And of course, you have mentioned all the biopsy program. These are the basic requirements in your laboratory. Can we go to the next slide, please? Now, the next thing, once you have this, the important requirement is training, which is your skills actually. So my question is, how do you train yourself? Can I put this question to Ravi?
Yes, sir. Thank you. So training is a basic requirement for any procedure the person or an embryologist can carry in an IVF lab. And that when it comes to an biopsy level of training, I think one should need to have a skilled person who has to be trained very nicely. So
Sorry,
as to
possible, can you switch on your videos as well for the panel discussion?
No, I'm not actually. My video is on only. That's what I call Sanket.
Yeah, the same thing. The same thing for me also.
Fine.
Yes, madam. As I'm mentioning that training is very essential for any embryologist who can do the biopsy. Otherwise, we will end up with a very taking out the biopsy sample in a very wrong way. Another thing is like, what is the volume of the sample that we need to take for our trophectoderm biopsy? Either it's in case of day 3 embryos or a day 5 embryos. Sometimes it is the chances of that we are going to lose the whole embryo also. So that's the reason training is not only with the biopsy, by handling of all the IVF equipments is very, very essential here. Without training, I don't think so I can able to say people can do it casually, the embryo biopsy.
Okay, over to Sanjay. Do you think there has to be a certain minimum number of embryos that you have to do? Is there a validation process?
Sir, definitely there is there is a validation process genetics labs do carry after performing or practicing on some we can say arrested or leftover embryos. Then we can validate it by sending some samples to the genetics lab. They give you the validation report. With that, we have to send one control tube, so that we can check if there is anything wrong. So
who should be doing the validation?
There can be internal, and then there's some we can get it validated from genetics lab also.
Okay.
Yeah.
Okay.
It's better to get it done by them, because for validation, when you send the samples for to lab to confirm whether there is a DN or not, so it will clear all the steps you have performed very well, and that will be the best thing to confirm that now you can perform.
Chandan, do you want to add?
I would like to. I was waiting for that. I would like to add a few points on this. See, with respect to my point of view, is training doesn't ends with when you do a proper biopsy and send it to the genetic lab and where the WGA passes. What I would think in my way is successful training should be once you do a biopsy, you should be able to make sure that the embryo survives back. It's no point when you have a WGO report with you, and if you don't know your freezing procedure, the refreezing procedure or freezing procedure normal, it's no point when you have a WGO report with you. So a successful biopsy, even we have to consider the thawing of an embryo, post thaw, how does it survive, and we have to make sure that what is the cell required. Only that much is needed for the biopsy. Say for example,
Are you saying that there should be some KPIs?
Yes, we have to definitely we have to maintain, and we should know where exactly we are supposed to shot the laser without damaging the blastomer. So these are the things which is very much important. It's not like you can just shoot at wherever at point and do the biopsy. There is a particular point where you have to shoot a laser for a biopsy procedure. How to load it, how to take the biopsy sample outside, how to load it without lysing them. There are a lot of key points which we have to remember in the training before starting an actual procedure.
I think Gayatri wants to add something.
Yes, sir. Training is actually divided into 2 steps, sir. Initially, it's a preclinical training where at least 50 oocytes or 50 embryos have to be biopsied by the candidate who wants to get trained. And the training has to be done under supervision of a recognized clinical embryologist. And then once they meet the requirements, there will be supervised clinical training where another 20 oocytes or embryos
And
have
the
to
human embryos?
Oocytes or embryos, sir.
No, I think it's better to train it on animal-based embryos.
Yes, sir. It depends on the local regulations or wherever it is. Depending on the local, might be mouse oocytes or embryos also, it can be used, sir. And then comes supervised where additional 20, in case the candidate is not well versed with the micromanipulation system. If they are not that experienced, then another 40 oocytes or embryos may have to be given for them to get efficient in doing that. And not only biopsy, even tubing also needs to be trained, sir. And once they learn the tubing, they have to be evaluated for the amplification outcome and also the survival of the embryo after the biopsy, and even freeze thaw survival also. And that's how they needs to be evaluated.
Okay. Dr. Varsha, can we see the recommendation? Okay. Training programs, it can be workshops, hands-on.
Yes, sir.
And one-to-one training, which is more, efficient.
Yes, yes.
One should be skilled in micromanipulation. Can someone, without micromanipulation skills to do embryo biopsy? Definitely, it's not possible.
Not possible. Yeah. But guidelines, like if somebody is that interested to learn only biopsy, then we may have to teach microbiology.
I think there are guidelines. I think people probably follow a SRI guideline, but there are countries. Say, for example, in Singapore, it's only PGD is allowed. There is no PGTA Act because they're still waiting for data on that actually. So there has to be certain numbers according to the guideline you can see on the screen. These are the numbers before you really start doing clinical cases actually for biopsy. So as Chandan mentioned, you'll have to look into post biopsy damage and survival, and then post warming actually. So you have to have an extremely good vitrification program, without which doing a biopsy, particularly at the velocity stage, would be disastrous actually. So there has to be validation of the embryologist by an experienced senior embryologist Or probably, there should be, like as a society, you should, look into, like how you can as a team, validate, visit centers and then, validate and then, kind of certify the embryologists. Actually, for that, you have to fix, certain numbers. Can we have the next slide, Dr. Osha? Prepare yourself. Now we have the infrastructure, we have all the materials that is needed, and you have developed the skills. Now, before you do the biopsy, how do you prepare yourself and decontaminate, before doing the biopsy? Actually, can we have your view, Swapna?
Yes, sir.
How do you prepare?
Yes,
that
sir.
you yourself
So,
do not contaminate the sample.
yeah, first thing is before starting the procedure, we need to clean the workstation as well the micro manipulator stage, and the tube block, whichever is there, we need to keep it on a sterile cloth or sterile surface. At the same time, always use DNase RNase free solution to clean the working area.
What solution do you use to clean the working
I
area?
use DNA, sir.
Mm-hmm. What
As
does it
well,
contain?
it is actually it's like the IVF graded. Sometimes we use even WUSAFE.
Okay.
I would like to add.
Okay, Sanjay, how do you set up for biopsy? Once you ensure that you are not, contributing to the contamination.
Generally, we make sure that at the time of performing biopsy, there is no any other procedure going on inside the lab, and with taking all the aseptic precautions for tools we are using, we put them, whether they are trial vials or biopsy pipettes, and sorry if I was not PCR tubes, and all these things we put into the laminar flow, and we put a UV light for 15 minutes, and then we start performing. Before that, routine cleaning is done that we do for performing any or micromanipulation.
Okay,
Hello. Hello.
Hello.
Hello.
Yes, sir.
Dr. Ravi, are you there?
Yes, sir.
Yeah.
Okay. Anyway, we'll just, summarize this, what is the recommendation? You'll have to wear protective clothing, and there should not be particles, coming out of that. Your gloves should be non-powdered. You are properly covered top to bottom. If you are wearing shoe covers, normally, of course, you don't wear shoe covers into your laboratory. You have a dedicated, pair of, slippers in the laboratory. And then, as the panel is mentioned, you have to use, DNA decontamination solutions. Ultraviolet irradiation can be done. Autoclaving of certain, things that you use. And bleach and 70% alcohol is not recommended. Okay, can we have the next slide, please? Yeah. So any IVF laboratory will have standard operating protocol. So you have to have a standard operating protocol which you have to follow accordingly. And then you select the embryos for biopsy. Anyway, that I think later there will be discussion on that. What kind of embryos you have to select. Minimize the duration, exposure of the embryos outside the incubator. Ensure that manipulator and laser is calibrated, particularly laser. You don't go and hit instead of the zona, inside the embryo. Ensure that everything is, reagents, all tools are available in sufficient quantities in case, something breaks, the pipettes and all that. And The most important thing, distress should be labeled, particularly because if there are more than one embryo, then you'll have to label it properly. There should not be mix up actually. Can we have the next slide? I think over to Dr. Varsha.
We've finished with the warm-up session. We've understood, we've discussed what are the basic requirements, what is the kind of training, and what is the setup we are going to do for the biopsy. But before we actually get into the process of biopsy, without I throw these questions open to any of the panelists who would like to opt to answer, and if anybody has a differing opinion to the questions we are discussing, then you can always come in. So the first question is, what is, when you know that a particular case is for embryo biopsy for PGT A, PGT M, PG T, SR, one, what is the method of fertilization that you would prefer for the embryos? And second, how would you prefer to culture these embryos then? So let's start with the method of fertilization. Anyone can take up that question.
Yeah, I would like to go for this, if you allow me to comment. Okay. In such cases, the method of fertilization, I don't mind whether it's an IVF or an ICSI procedure, provided certain precautions must be taken before that. See, for example, if it is an IVF procedure, when you inseminate the oocyte and you check for the embryo formation, there are certain key points which you have to note down. First, you check the fertilization to make sure that whether it's a 3PN or 2PN with single polar body or 2PN with two polar body or
sorry to interrupt, Dr. Chandan. We're just discussing the method of insemination. What is the method? We're not going to, we're not discussing how we're going to assess the fertilization. You prefer IVF? You don't mind either? What is your take?
I don't mind. I don't mind. That's why just giving justification why it was both. So I don't mind whether it's an IVF fertilization or an ICSI fertilization. I'll go for both, provided certain precaution must be taken to avoid the cross-contamination by the sperm. In case if it is an IVF, it will adhere on the zona. So during your biopsy, that may cause a cross-contamination. So that precaution you must take care. So I don't mind whether it's an IVF or an ICSI.
That is why it's better you go for ICSI only.
How will you, what is the precaution you will take that the sperm doesn't attach itself to the zona in IVF?
So I would always go for a short insemination, just wait for 4 hours and make sure that it is denuded and check for it on the next day. As a short insemination.
Suggesting that brief insemination or long insemination prevents or increases the chances of, because the sperm have to attach themselves to the zona irrespective of the time of insemination.
Yes, exactly. Yeah, and also we have to make sure that there is.
Yes, ma'am. Preferred method will be intracytoplasmic sperm injection, ma'am.
Yeah, it is always better to go ahead with ICSI. Why to take a chance? Like
yes,
there is like
the maternal contamination, genetic contamination.
Yes.
So we have to make sure that cumulus cells.
So there is a failure issue always. Apart from that, there are contamination chances as well in the culture. Yeah. So why to take a chance? It's better always to go ahead with ICSI.
Okay, and how would you then culture these embryos? Any particular? Yes, Dr. Gayatri.
Initially, we can do co-culturing, ma'am. There need not be a separate culture. Group culture. Yeah.
Okay.
Initially, later once we select the embryos. So during the biopsy or after biopsy, they have to be kept separately and with the labeled the numbers. That's it. Otherwise,
I would always go for a group culture for till day 3. I always prefer day 5 biopsy. So till day 3 is a group co-culture, and from day 3, based on the number of division, how the pattern is divided, and based on embryos assessment, it is segregated into individual culture and then do the biopsy.
May I come in?
Yeah, please come in, Doctor.
I think culture method is not an exactly that how it can be an individual culture or it's a group culture. That won't make any difference here.
Yes. Okay. So to conclude, and this we're purely going by the ASHRAE PGT consortium guidelines. This whole discussion is based on the guidelines that have been provided by this group. So the preferred method, still recommended method for fertilization continues to be ICSI as per recommendation. This is to prevent any paternal contamination, that is contamination from the sperm. Yes. Secondly, these oocytes need to be adequately denuded of all the surrounding cumulus cells. While culturing the embryos, if you do have the facility of a time lapse, then that is preferred, so that there is continuous uninterrupted culture, which is again beneficial for the embryo development. A closed culture system is preferred. Like the panelists said, yes, before you biopsy them, it does not matter how you culture them, but post biopsy, you would want to culture them individually or after you have selected the embryos for biopsy. There are different types of dishes that are available, multi-well dishes, or our simple 60 by 35 mm dishes. We can make individual droplets, and we need to ensure that there is no accidental mixing up of these droplets if we are using dishes which do not have individual wells within them. While shifting the dishes, we need to ensure that there is no accidental mix-up when the dishes are shaken. So that is important. Having said that, I want to also bring the focus to this particular paper wherein around 927 patients who underwent IVF PGD cycles, 300 odd went through the process of IVF insemination, and approximately 500 odd, close to 600 patients went through ICSI, and there was 47 patients who had IVF and ICSI, both as the methods of fertilization. What this paper revealed to us and concluded, I do agree, these are small numbers to take home any message, but there was no difference whatsoever which was observed in the percentage of complete, incomplete diagnosis or any evidence of any PCR failure or abnormal embryos. And not a single case of misdiagnosis was identified in this series. So the investigators concluded that it may not be necessary to always consider ICSI as the method of fertilization. However, having said that, the recommendations are still to go ahead with ICSI as the method of fertilization. Now, this becomes important when you have certain embryos which you've already frozen and kept, which were not anticipated to have gone through embryo biopsy, and they would be fertilized with the procedure of IVF. In that case, only because they were fertilized by IVF, it does not make them non-applicable for embryo biopsy, and you could still consider them for the procedure of embryo biopsy. Now we move to the core topic of embryo biopsy. We know that embryo biopsy can be done at different stages, starting from polar biopsy to today, ectodermal biopsy, including cleavage biopsy. There are very few people who also do biopsy at the morula stage, but today we will concentrate on I would say blastomere biopsy, day 3 biopsy, cleavage stage biopsy, and blastocyst or ectodermal biopsy. Now, if you see the graph on the right-hand side, what is very significant is, and this is from the ASHRAE PGD Consortium, their data collection from 2009 to 2013. And as you can see, there is a slow but significant shift of the preferred stage of embryo biopsy now moving towards blastocyst. So earlier in the first data collection, majority of the cycles were cleavage stage biopsies, but now you can see from 0.2% to almost 23%, and this is in 2012, 2013. Now we do see that this number is significantly increasing, where more and more centers are opting to biopsy their embryos at a blastocyst stage, and this is just right, as we do know a lot of paper have come out that in the version 2 of PGS, it is biopsy at blastocyst stage and comprehensive chromosome screening. So with that, now first we will move over to day 3 or blastomere biopsy. So now we're going to address 3 questions here. First, let us start with criteria for embryo selection. Now we're discussing day 3 or blastomere biopsy, cleavage stage biopsy. So any of the panelists can volunteer and tell us what is the minimum required grade or quality of embryo that you would have if you are considering an embryo biopsy.
Is it, may I come in, madam?
Yeah, sure. Please come in, Doctor.
Is it of day three blastomere biopsy?
Yes.
Yes,
Now we discuss yes.
Only, okay. What we have to consider here is the quality of the embryo based on our morphological structure only. Having a minimum of 8 cell. Even I don't say it is a 6 cell is required. If it is more than 8 cell, it is good to go for a biopsy of blastomere biopsy. And it has got a equal blastomere in size and shape, having.
You are muted.
Inside the blastomere. That we have to make sure that the presence of nucleus and nuclei inside the biopsy before you select the particular blastomere of an 8 cell embryo.
Okay.
So,
any other? Yeah, please come.
Okay. So that's what I agree with the point which Dr. Ravi told. It's basically a grade A embryos where it has at least more than 6 cell, preferably 8 to 10 cell, and equal number of blastomer. And if we can't expect all the embryos to be all grade A, certain time we may have to end up doing biopsy with different form of embryos which we get. So in that aspect, I would say embryos which is having less than 10% of fragmentation, still you can consider that for the biopsy. An embryo which is having more than 30% of fragmentation, I don't prefer for a biopsy. So it's grade A completely, or embryos which is having less than 10% fragmentation.
Okay. So what are the minimum number of cells that you would opt for? If you have a 5 cell and the fragmentation is less than 10%, there is no evidence of multinucleated blastomere. Will you still consider it?
May I?
Yeah.
Yes,
yeah.
Yes, ma'am. It depends completely on patient for what actually they are going ahead with the PGS. And in case if they have some genetic history, there is no option. They have to go ahead with the biopsy. So it depends completely, like if the cell number is more than 6 cell, whether the fragmentation rate is 10% or 20%, I think we should consider those embryos.
No, my question is very clear. Yes, if the patient is for PGTM, right, and the patient has to avail of the embryo biopsy, that's another question.
Okay.
My question is very clear. What is the minimum level at which you will consider the embryo for a biopsy?
It is like more than 6 cell, and the fragmentation should not exceed more than 30%. And the blastomeres should be like equal blastomeres, and the nucleates need to be very clear with a single clear nucleus.
Okay. So a minimum of at least 6 cells is something you would want to see in an embryo. Fragmentation of less than 25%. A higher fragmentation pushes the chances of a misdiagnosis and a failed diagnosis. That is the risk we carry. So one is, of course, the survival of the embryo post biopsy. The second concern is also a misdiagnosis. In such a scenario, if you really have a poor quality embryo and the biopsy is a must, like what Swapna said, then you could still consider taking the embryo to the blastocyst stage if it is poor in quality. Like one of the panelists said, I think Dr. Ravi, that you need to ensure that there is a single nucleus. So they are mononuclear blastomeres, and you will eliminate multinucleated blastomeres or multinucleated embryos here. Now for the panelists, I have these 4 embryos here, and which according to you would you have to select only one for biopsy? Which is the one you will opt? Can we start with Gayatri? Each one of you can give your choice. Which is the embryo you will opt for biopsy? Number 1, 2, 3, 4.
Second one, ma'am, I would prefer.
Anybody else with any other opinion here?
It's second one.
If provided you compulse day 3 biopsy, if that the 16 cell third embryo, it's around 16 cells, so it must be day 4 embryo.
No, these are day 3 embryos.
No,
these are day 3 embryos. This is the morphology. This is how it actually looks like. So I want opinion from the panelists. You've got to select just one embryo for biopsy, and which is it that you opt for? Because we now
I can opt for the second and third.
I would go for second because the reason behind, though I would go for second, the reason behind is you can see you can see the nucleation very clearly. Whereas the third one, in spite of having more number of cells, but the nucleation is not that clear. So this is almost like 3, 6, maybe 6 to 7 cells. So I always go for the second one.
Yes, I think all of our panelists have got it right. We would opt for the second embryo, where it is an 8-cell embryo. You can see the nucleus very clearly. It would be good to biopsy this embryo. The problem with embryo 3 is, as the number of cells divide, we all know that it is very difficult for us to visualize the nucleus. Right. Second, when you biopsy an embryo that has divided to 16, 18 cells, and if you want to freeze it, there is a very high risk that the other embryos are going to escape through the zona, the breach in the zona that you have created for such an embryo. So yes, number 3 is going to pose the challenge of we not being able to identify the nucleus there. Number 4 is a compacted embryo. Even if you try to decompact it, it is going to be a tricky and a messy biopsy. Embryo 1 seems to show a higher percentage of fragmentation. Now, the second question was, what are the different methods by which we can do embryo biopsy on day 3? You can just name the methods or the method that you prefer to do. Before that, let me ask the panelists, which day embryo biopsy do you all prefer? If each one of you can tell me.
Yeah,
so
we
I
prefer
would
blastocyst, day 5 embryo and day 6.
Yeah, me too. I prefer the day 5. Right?
Yes,
Day 5.
blastocyst.
Blastocyst. Yeah.
Yes. So all are for blastocysts.
Yes.
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 So just to complete the list, can somebody name what are the different methods by which we can do a blastomere biopsy?
Yeah, one is we can do with the mechanical zona drilling. That is one possibility. Another with
acid turret.
Blastomere biopsy, day 3 biopsy.
Yes. And the laser last ultimately.
Sorry?
Laser hatching, he's talking.
Laser hatching.
Yes, you will have to hatch the zona. So we hatch it by the laser method, but are there different ways in which
aspirating, yeah, ma'am.
Yeah.
Aspirating the blastomere and expelling it out.
Okay.
No.
Okay. Okay. So let me go to that. There are practically, there are multiple methods by which a blastomere biopsy can be done. One is the aspiration, where you breach the zona, the biopsy needle gets into closer to the cell which you wish to biopsy, and you aspirate it out completely. The next method could be you partially aspirate it and then pull out the blastomere. Third could be the expulsion method, where here the advantage is the breach in the zona is smaller than what you would need for the aspiration method, because you're not inserting the needle inside, but then by putting traction or pressure on the zona, you will push the blastomere outside. That is the expulsion method. There is also a flow displacement method, wherein you can push in media and then expel the blastomere, but this is just to complete the list. Second, pre-biopsy, yes, you would like to take some measures. As far as the blastomere biopsy, would you just take the embryo, directly go ahead with biopsy? Or would you like to put them, expose them to certain media for some time?
Yeah, ma'am.
Calcium, magnesium.
Yes.
Especially when it is a day 3, no, definitely it must be strictly fibroid with calcium magnesium free medium. And if it is a day 5, even your regular calcium medium will go for.
Yes. So for a day 3 embryo, you would like to expose them for 8 to 10 minutes or even less to calcium magnesium free media to then release them of the junctional complexes, which makes the biopsy much easier. And post biopsy, you would like to rinse the embryo well, also the biopsied cell well, before tubing it. You need to note if there is any lysis or a disintegration or degeneration of the blastomere. Last is, how many cells would you like to biopsy?
Single cell, ma'am.
So if it is a day 3, single cell is enough. Or in case if you're going for a day 5 biopsy, at least 4 to 5 is maximum.
No, only 1 or at the max 2, madam.
It's, yeah.
Dr. Chandan, did you say
Yeah.
Morula?
No, not Morula. I'm not talking about Morula. It's about if it is a day 5.
Yeah.
If it is a day 5, so
no,
3
blastomere. Let us just focus to
blastomere. Okay.
It is always better to, yes, ma'am. It is always better to take 1 blastomere.
1.
If it is necessary, we can take max 2.
For even if it is a 2 for 8-cellular embryo,
take 2
it is
blastomere.
25%. So we can go with the 1 single blastomere with now advanced technique like single nucleotide polymorphism gives good results.
Madam, can I have one clarification from your side?
Yeah.
Acha, the previous slide which you have showed about 8 to 16 cell embryo, in case if they all the cells having a nucleus, so in that condition, can we go ahead with more than 1 or 2 cells, more than 2 cells for day 3 biopsy?
Okay, so we're coming to that question now. How many cells do you aspirate? Right now, the concept is very simple. One, the number of cells at day 3, the embryo is not differentiated, right? Which means that we do not know the commitment of each individual cell that we are going to biopsy, whether it is committed to form the embryo proper or the extra embryonic tissue or the placenta. Right now, here we are considering the loss in volume. Now consider a 8-cell embryo. When you remove 1 out of 8 cells, there is a loss of almost 12%. On the other hand, if you happen to remove 2 cells out of a 8-cell embryo, the loss in embryo volume is 25%. Now compare that with a blastocyst, where you know a blastocyst has probably 150 to 200 cells. But if you look at just the trophoectodermal cells, even if they are say 100, you remove 5 cells out of that. The embryo loss or the volume loss is barely 5. Right? Compare that now to a routine of 12 to 25%. So that is important. So there is a huge volume loss when you increase the number of cells that you biopsy. So when you biopsy more cells at the blastomere or the cleavage stage embryo, maybe it may help you for a better diagnosis, though there is no good evidence to suggest that with the newer platforms that are available, but you will be causing more harm. Right? So hence recommendations, you still prefer to biopsy only a single blastomere. Right? The drawback is, yes, the risk or the incidence of mosaicism cannot be detected here with a single blastomere, but that is the drawback of this stage. Right? With 2 cells, it may improve your diagnostics, but considering the massive loss of cell volume, it definitely impacts the embryo development. Now, Swapna said, yes, we can remove 2 cells, right? Now, where is the question? Where would you consider removing 2 cells? One, when you remove 1 cell, there is a lysis, then you want to go in and consider biopsying another cell, right? Now, so when we are considering rebiopsy, at this stage, it would be better to grow the embryo to the blastocyst and then probably consider a rebiopsy, right? So then, to sum it up, the important aspects of blastomere biopsy: proper positioning of the embryo, hold the embryo firmly by the holding needle. You should have a good control to the aspiration or the biopsy needle. The biopsy should be quick, definitely, but it should also be gentle. A very brief exposure to calcium, magnesium free media prior to biopsy. Always identify the blastomere where there is a visible nucleus. Otherwise, you might be removing a fragment without a nucleus and it's not going to help you much. If there is a lysis, you need to change your micropipette. In case of a rebiopsy, if you're considering a rebiopsy at the same stage, you don't have to create another opening. The same opening has to be used. Better would be to consider culturing them to blastocyst and then biopsying them. Next, coming to blastocyst biopsy, over to Dr. Suresh Katera.
I think you have got to know what are the advantages and disadvantages of blastomere biopsy. If you look at it, one two blastomeres to help you to get a better diagnosis. The problem here is also actually, as Dr. Walsha mentioned, it will reduce its implantation potential. Now we know that each blastomere is totipotent. Now when you remove it, the amount of inner cell mass that is probably like contributed will also come down. I still remember in the early 2000, UCL London used to say that the implantation rate of these embryos came down to half of what they used to get for an embryo which was not biopsied. So which means, the disadvantage here is that, if you want more cells, it will reduce the implantation potential. So what is the way forward? So over a period of time, we have looked into other options. So though, blastocyst biopsy was considered in the early 90s. So currently, the practice majorly is looking at blastocyst biopsy, unless otherwise there is a regulation in certain countries where you cannot do blastocyst biopsy. Now, the first question is, when do you perform assisted hatching? Now, you monitor the embryos from day 3 onwards. You will see which is the one which is most progressive in an advanced stage. And do you do biopsy on that day or the following day or on the day of the biopsy actually? So let us have panelists view. Let us start with Chandan.
Yes, sir. I would say that in case if we have a laser system which is there on the unit or on the hospital, just check the embryos and see which is like how, with respect to the morphology, how they are dividing. So you have an observation from day 0 to day 4 or day 3, how the morphological changes is happening. So when you've segregated and decided that, okay, these are all the embryos which I'm going to biopsy, to make your biopsy procedure easier, give a laser shot on day 4 and just wait for the embryos, the tropactodon to come naturally outside, so that your biopsy procedure will be much easier rather than you making them on day 5 and forcing them to come out. So even that can be done, but to make the process very easy, to a day 5 laser hatching and wait for day 5.
Do the other panelists share his views actually? Gayatri?
Sir, actually, I think, yeah, sorry.
I would prefer on day 5 expanded blastocyst phase, sir. Simultaneous zona pellucida opening and tropactodon biopsy.
Okay. What about others?
Yes, sir.
Sorry, may I in?
Hello? Yeah, hello. Can you hear me?
Yeah, if it is a day 5 embryo, certainly we need to just analyze this quality of the embryo and its tropactodon cells. On that basis, we have to suppose, in case if you wanted to do it on day 4, you can give one laser shot and then wait for till to herniate and do the biopsy. Otherwise, on like cavitating embryos also can be given one laser shot, and then still we can wait for get to herniate and then do the biopsy. That is also one of the good procedure, what I feel personally.
Okay, Swapna, is there any disadvantage by doing so?
Yes, sir. Actually, it's better to do it on day 5. And it again, if you are whether it is a fresh embryo or the cryopreserved embryo. In case if you are taking a cryopreserved embryo, thaw and allow the blastocyst to expand and give the assisted hatching and allow it for herniation. After 3-4 hours, once the tropactodon herniates, then we can do the biopsy.
I would like to add.
Okay,
please, Sanjay.
Yeah. So I was saying, if we hatch it day before, we don't know exact position of the inner cell mass. So we don't know, it can hatch it from other side also. So that's why it's better to hatch it. I prefer hatching it on the biopsy day, 2-3 hours before the biopsy. We select the embryos and we separate them. And
does a biopsy per se in any way interfere with the expansion of the blastocyst?
Sorry, sir.
Biopsy itself on day 3 will in any way, interfere with the expansion of the blastocys. Will it be disadvantageous?
There actually some reports suggest that with the hatching done with a laser, the zona doesn't get recovered with that. So there can be either multiple hatchings or there can be a problem with the expansion.
So there are different views here actually. Either you can biopsy on, do a do it on day 5 itself, wait for a few hours, or you let the blastocys hatch on its own, but there is a risk actually. Some blastocys may not hatch. Either way, there is advantage and disadvantage. It again depends on how busy your center is. I read in one of those articles where they biopsy on day 3 and allow them actually to grow to blastocys actually. This is to avoid additional cost for every embryo actually. And then it gives them the opportunity to do a double biopsy. So if you are doing on day 3, probably you'll be when we are talking about uninterrupted culture, you are taking out embryos on day 3. You are doing a laser shots and then allowing, so that your job will be reduced, if it hatches. Now the practical difficulties are that on day 5, not all embryos will become blastocys. Then you may have to go on to wait until day 6, which again actually it will be additional cost in terms of disposables and consumables. So there are different approaches to that, and probably it depends on your personal preference and then how busy and workload in your laboratory. Next slide, please. Yeah. So what are the different methods you can use? People, there are 2 or 3 different methods, where you can remove the trophectoderm. Can one of you elaborate?
So
Ravi?
one is, yeah.
Sir. Different method means like we are using the same kind of method that used for blastomere biopsy, like laser. There are the laser as well as
no. How do you remove the cells?
I think, sir, after hatching, pull and stretch. I would like one technique, and flick method is another technique.
Yeah. Yes.
2 main techniques everyone use, and one more technique we perform generally with some embryos. It doesn't happen with all. When we do hatching 2 hours before, and then at the time of biopsy it's already herniated, we just aspirate few cells and keep it aspirating, and then without giving laser shots, we try to flick it and it comes out. Yeah. So we try to minimize the laser shots. Yeah.
That's what, sir. That one is in case if we when you perform a biopsy, if it comes easily, then no need of laser shot and fine. Sometime stretching need a laser shot. Yes, you do a laser shot. Sometime what happens, even after laser shot, there'll be, because of the elastic stickiness in nature, it goes back. It tends to go back into the embryos. So in such cases, if it is very difficult to remove, you just do just slash it on the holding your holding pipette, so that it can separate it out.
Okay.
So I need one clarification, sir. Actually.
Mm-hmm.
If the blastocyst is completely hatched out, how can we remove the trophectoderm cells?
I think there are different techniques available, whether you are able to hold the blastocyst, with your holding pipette. If you are not able to do that, you'll have to use the flick method or something. We'll
Yeah.
have to,
Okay.
Yeah, flick is the best method because I have done one day's completely hatched embryo where
Okay,
you're
so
pulling and holding hardly doesn't make it completely
it will
destroys the embryo.
They're more
yes.
sticky.
Just hold and flick it.
Hatched, yeah.
Yeah,
Okay.
just flicking.
Okay.
Flick method is the easiest way of
Okay.
completely hatched.
Thank you. Yeah.
Okay, I think we are running behind the time, so we'll have to skip, some of these things actually. Can we go to the?
So I think we've dealt with blastomere biopsy and trophoectodermal biopsy. We just have maybe 5 more minutes. I want one of you to tell us the benefits, the advantage and disadvantage of blastomere biopsy.
So may I?
And if there is any varied opinion, then the next person can come. But if all of us agree on that, let us not repeat the points. Each one of us one or two points of.
Yes, it's better to go ahead with the trophectoderm biopsy.
No, the question is, tell me the advantage and disadvantage of
advantages of. Yes, ma'am. Advantage of trophectoderm biopsy is you have blastomere.
Yeah.
Okay. So the cells are totipotent at blastomere stage, as you said, ma'am. So still the cells are not committed to their respective pathways like ICM or trophectoderm cells. So
advantage
for blastomere, yeah.
Trophectoderm
is important.
Yes, there is an advantage, ma'am.
Yeah.
So the results, the cycle can be the embryo transfer can be done in the same cycle. We can wait for the results to come and we can finish the transfer in the same cycle.
You don't need to freeze the embryos. You could biopsy it on day 3 for 2 days and do a fresh transfer once the results are available. Excellent. Any other advantages? What are the disadvantages?
Disadvantages I can.
Yes.
With respect to the mosaicism, it's all a tutipotent cells. We never know which cell going to result into. See, sometimes we may end up taking a cell which may result into even ICM. Then you will have a blastocyst where you don't have an proper ICM development in that. So we never know which cells going to result into which. So you may end up taking the cells which you may contribute in result of an ICM. And the second thing is, and again, the mosaicism which we talk about. But mosaicism is not like, say, for example, out of 8 cells, if 2 cells are probably abnormal.
Chandan, what about mosaicism? What is it about day 3 embryos?
Early cleavage, in cleavage embryos, it is said, and mosaicism chances are higher. Higher. Of different cell lines, yeah. Comparatively
as they grow towards blastocyst, there is autocorrection and then
Exactly. If you end up taking 2 cells which may result into mosaicism, like you will have a result which is you can't compare. It turns into a mosaic result. So whereas if you do a trophectoderm biopsy,
chances of misdiagnosis are slightly higher on day
2. Exactly.
Any other?
Still 2 is a number less comparative to the trophectoderm 5 to 6 cells. That is also another thing.
Okay, the excessive depletion of embryo cell volume. Yes, Gayatri.
Another thing is what I mentioned here. Chances of arresting of day 3 embryos is more, madam, in that.
Yes, embryo development is compromised. Very good.
Chances of getting arresting.
Yes, excellent. Yes, Gayatri, you wanted to come in?
Yes, ma'am. Mitotic errors won't be diagnosed with blastomere biopsy, ma'am. Mitotic errors.
Mitotic errors will not be diagnosed?
Yeah.
What are we diagnosing? So you're saying mitotic errors like mosaicism, right?
Yeah.
We're not saying all mitotic errors. So let's be specific. Mosaicism cannot be diagnosed because we're biopsying a single blastome, right?
Yeah.
Let's come to blastocyst or trophectodermal biopsy. What are the advantages of biopsying at that stage?
Increase number of cells, like 5 to 10 cells. So more reliability of the diagnosis, ma'am.
Diagnostics.
See, itself, going to blastocyst itself is a good filter that to choose best embryos out of the lot we have, because as a morphology itself, a good representative of the nucleidi,
And so it's better we can reduce the number of samples we are sending for the biopsy to
Yes, so
minimize
the
the cost.
reduction of workload, drastic reduction, yes, only those embryos which grow well to blastocyst, because if we do a biopsy on day 3 and the embryo doesn't grow to blastocyst, then you wasted your effort into biopsying that. Very good. Anything
There is
else?
one more assumption that, ma'am, actually day 5 blastocysts are more resistant to biopsy compared to day 3 embryos.
Resistant, I don't
In
get
the sense, like day 3 embryos are like more prone to traumatic by biopsy, like compared to day 5 embryos.
Yes, so the survival and embryo development can be compromised. It was said by one of the panelists earlier. Yes. So
And it will not harm the embryos in any way. If you take a little spray of whole cells of the propactidome, it doesn't harm the any way with respect to the implantation.
Yes.
Yeah.
Yes.
Another thing I wanted to raise here is frozen thawed embryo survivability is better in case of blastocyst.
Excellent. Yes. 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 Cryopreservation post survival is much more better, right? What any disadvantage of doing a biopsy at blastocyst stage? No disadvantage.
Only it comes like cost factor. Patient have to bear some, to freeze and to thaw, and next cycle to again undergo entire procedure of, to prepare the endometrium.
Right. So let us go to the pros and cons. Blastomere, yes, we looked into all the aspects. In fact, the highest worldwide experience is with day 3 embryos. Over time, I'm sure in the next 4-5 years, we'll have more experience with TE biopsy. With blastomere biopsy, the chances of misdiagnosis is around 10, less than 10, but 10%, whereas the chances of misdiagnosis with TE biopsy are much lesser, less than 3 to 5%. So that is a bigger advantage. However, with TE biopsy, yes, mostly it may be required to freeze the embryo. Second, you need to have optimal culture conditions to have good blastocysts for biopsy. So that is mandatory. A good cryopreservation program is needed. And second, optimal culture conditions are needed. More than that, I want everybody, I just want put this slide here to re-emphasize, and there are enough and abundant evidence in literature that with a day 3 biopsy, the chances of, the reduction in embryo development, the embryo survival, post-freezing, the reduction in implantation and overall detrimental effects of blastomere biopsy. So there remains no doubt absolutely that biopsy at the blastomere or day 3 stage does harm the embryo. Time-lapse studies have suggested that in fact the biopsy stage timeline is much more prolonged. Compaction can be affected, blastulation, not only that, even the process of hatching can be affected. Obviously, there is reduced implantation and survival of the embryo. So this is something we need to bear in mind. So it's time that we moved over, all of us, to blastocyst biopsy and leave behind blastomere biopsy. It's good to start with. When we start doing biopsy, it's good to know how it's done. But in clinical practice, yes, always the priority should be for a blastocyst biopsy. And I'm told we're falling short of time. So we are going to skip the next the questions, and we would, before that, I'm sorry. So just to conclude on our panel discussion, this is an old paper, no doubt, by San Diego, Munne and team, but it stands true even today, that the biggest reasons or the biggest causes of a PGT program not taking off successfully is because of lack of expertise in embryo biopsy, in embryo fixation, genetic analysis, and patient selection. So these are 4 most important aspects of having or running a successful PGT program. That is what we need to emphasize, that all these 4 corners of a PGT program are in place. when we start off a PGT program. And to conclude, I would request all our attendees to go through this paper, which is latest 2020 ASHRAE PGT Consortium on good practice recommendations. These are recommendations if you're starting off with the PGT program in your clinic. It gives you all the details, not only how to biopsy, but also how to train yourself, what is the minimum requirement, what is the QA/QC that you need to have in place, and what are the KPIs and how do you monitor your program. So with that, I would like to thank ACE for giving all of us this wonderful opportunity to be here and discuss on this very important topic. I thank all my panelists. They have been excellent. So on behalf of my co-moderator, Dr. Suresh Katera, and myself, I thank the President, Dr. Ved. I thank the Secretary of ACE, Dr. Sujata, the Vice President, Dr. Sanjay Shukla, and our coordinators, Sanket and Dr. Ravi, and thank you so much.
Thank you, ma'am.
I would like to thank ACE team for having me here, and it was a great interaction. Unfortunately, we ran out of time. We couldn't complete. Thank you all panelists. Thank you, ACE team.
Thank you, sir.
Thank you.
Thank you very much, sir.
So thank you everyone for this wonderful opportunity.
Thank you, everyone.
Thank you so much all for this wonderful panel and emphasizing on various aspects of D3 and T biopsy. So now I would like to invite Dr. Sanjay Shukla sir to give a vote of thanks.
Thank you, Sanket. At the onset, it was a wonderful planning of Team ACE, especially our team members from Karnataka, who came forward and decided to take this opportunity to have a scientific event at their own. And that's what we strive to have, many more such events from different regions of India. And on one hand, this pandemic has limited us to certain areas, but at the same time, it has also given us an opportunity so that many other team members can participate in academic activities without leaving their homes. So I invite all enthusiast members who are willing to do such activities. We'll let them prepare the template, and then they can always come back to us, all the seniors who are there in their states, and then together we can plan, we can have a better scientific program with the help of seniors, and let you people do this with the zeal that you have shown today. So I congratulate my friends like Ravi Nirvani, Sanket Dhumal, and all other people in Karnataka. I would also like to take this opportunity to thank our esteemed experts, Suresh Katera sir, my colleague and friend Dr. Varsha, Vijay Kumar, and all other people who have contributed to this wonderful academic evening today. Thank you. Thank you very much.
Thank you, sir. Thank you so much.
Thank you very much.
Thank you. Thank you.
Thank you all.
Thank you so much.
Thank you so much, Ved sir and Sujata ma'am, for this opportunity.
Thank you. Komal, you have
Yes.
to wait, please. You have to wait, please.
Okay.
Okay.
Okay, doctor. So thank you
Actually,
so much.
I want to continue this meeting. Four
Okay.
people will be there. So
Okay.
you all have to leave. I will tell you at what time. Just
Sure.
wait.
Komal will do one thing. We will actually stop the recording.
Yeah,
okay?
you please stop the recording. Please stop the recording.